Good evening, good morning, good afternoon, everybody. Firstly, I hope that everyone is safe and healthy despite the difficult conditions that we are still facing. Now, before we start, I just want to remind everybody that we will be recording this talk so that we can circulate it to everybody afterwards. And I would ask that all questions are left in the Q&A section, and we will address all of those together at the end of the talk. So it's my pleasure as the CEO of Leo Cancer Care to welcome all of you to our second webinar, exploring the efficiency and workflow improvements that can be obtained through the use of upright patient positioning in radiation therapy. Now, during our last talk, Rock Mackie, our chairman, described the clinical benefits of upright positioning, but this evening's speaker will give us his insights into the clinical applications of this technology. So it's my absolute pleasure to introduce Leo Cancer Care's very own President of Proton Therapy, Niek Schroeder. Now, Niek has long been a visionary in the particle therapy space, and it's many of his ideas that have really driven the industry to where it is today. So enough of me talking, Niek. I will hand it over to you, and I'll pick up the questions at the end.
Great, thanks, Stephen, and thanks for the nice introduction and the opportunity to walk us through this workflow and efficiency improvements. So as we start, first jump one slide, we want to just talk a little bit about proton therapy cost comparisons. Now, I want to make a disclaimer up front. I'm a proton therapy guy, and a lot of the stuff I'm saying is going to be in the context of proton therapy, but I do believe when it comes to efficiencies and all those benefits, it 100% also apply to the X-ray space. So the next thing I want to talk about is the why for upright radiation therapy, and then we'll just talk about efficiency and workflow improvements based on clinical data, clinical papers that's been published, and then we'll touch on a couple of remaining challenges that we still need to address. So I want to start with this slide, or this cartoon that was made by Harold Paganetti when he had a review session or a point-counterpoint discussion about, the question was, did we reach a plateau in terms of the dosimetric index or the ballistic benefit? That really is the question, is how well can we conform the radiation dose to the target using either photons or protons. You can see in the beginning days, there was really no difference. It was very early days for radiation therapy. And then the CT scan that came to clinical use, so that the proton folks could then start using the Bragg peak and say the beam can now stop somewhere. And suddenly we had a huge uptick in terms of the ballistic benefit because there was no exit dose. Then a couple of years later, the photon guys had a huge uptick when IMRT and IGRT came into the mix. And here we can see it in the late 90s, there was again a very narrow gap between protons and photons. And then, of course, protons started with the clinical realization of pencil beam scanning and make another big step. But we can see there was very little improvements. Now, of course, this is not, this is just speculative data. And there's a lot of reasons to argue that maybe something like the MRI Linac gave the photons an uptick. But that's not the point. I think there was very little growth in the ballistic benefit in both forms of radiation therapy in the last 20 years. And the question is why? And the question then also is what can happen towards 2025? And so I just want to quickly walk us through a cost comparison based on time and manpower and reimbursement for protons versus photons. And if you look at the cost and money aspects of a proton therapy facility, it's very clear and easy to understand that protons is about 3 times more expensive than photons. If you look at the time, the equipment, and procedures and staff, and which basically workflow, then it's also 3 times. We need actually manpower. We need about 3.8 times the staff to treat patients with protons than with X-rays. And if you look at the reimbursement, then classically in the United States, CONSTAP, it's only 1.3 times more. So no wonder it's hard to make proton therapy centers financially viable. And there's really no money available because these centers are so expensive and they're hard to make financial gains, and there's just not enough people in the field to improve the dosimetric index. So the question then is, what can be done to remedy this situation? And if I look at the cost and money, then there's certainly an opportunity. If we can reduce the size of the equipment and the size of the buildings, then and we can reuse existing infrastructure, then we can bring that cost down. And we can work on efficiencies and workflow improvements, we can bring the cost down, and also if we can improve the workflow, so you don't need that amount of people, that huge number of people to do treatment planning and to set the patient up in the room and operate these massive equipment, then we can probably do something there. And then on the reimbursement side, that really just depends on the clinical rationale and evidence, which I believe today is very well founded. So if we do these improvements and changes, and we can use existing infrastructure already, but then we now have a picture that looks a little bit much better, and that's kind of where I think we want to be by 2025. And this evening's or this morning, depending what time of the world you are, this lecture, I hope to walk you through, and at the end of the lecture, you guys agree with me that this is feasible and doable. Now, about a year ago, I was asked by Tony Lomax to write a book chapter on or a paper in a special edition of the BJR on what is required in the next 10 years for proton therapy systems to what should they be able to do additional to what is happening today. So I asked Jacob Shamblin to co-author this paper with me, and we came up with 8 things. Now, we probably would have come up with 15 things if we had more room in the paper, but we were limited to 4,000 words on the paper. Came up with 8 things, and it's interesting that the things that we came up with, every one of these aspects addresses workflow and efficiency enhancements. And any one of these things are stuff that now exists in the academic centers. We developed it, papers been written on it, but it now lacks implementation. And so the paper was written towards the vendors to say, this now exists, and this is how we should do it, and to move forward with proton therapy. Now, if you look at what Harold then said, and he's continuing his debate 5 years ago, he basically said that this can actually happen with the ballistic benefit or the symmetric index in protons. If this was Harold's list, adding cone beam CT, Monte Carlo, RBE painting, in vivo verification. And I want to further elaborate on how we can actually do this at the 2025 timeframe. And here's the list of things that is in the BJR paper that I just referred to. Things like proton radiography, prompt gamma, prompt PET, flash therapy, real-time adaptation, grid therapy, dual energy CT at isocenter, and optical guidance. And the question is, how do we do this? And I'm convinced that the answer is, this is possible through upright treatment positioning. Most of these features are easier to implement and more feasible in an upright position. The question is then why? I mean, I have to be able to convince you that this is possible, and this is why I believe it's possible. So the next couple of slides are going to talk about why upright radiation therapy, what is the driving force behind it. And there's about 6 or 7 points that really drives that movement in the industry, driven by several companies, of which Leo Cancer Care is the solely focused on developing technologies to do that. So the first thing, why upright treatments? Because several research papers now show that upright treatments are highly feasible and have many benefits to the patients. The economics of particle and proton and particle therapy demand cost-effective solutions, and upright treatments will also have huge cost ramifications in the photon space, primarily through shielding and the space that the photon upright linac would require. We need to break the stalled state of improving the dosimetric index in all radiation therapy. So this really is my passion to see, can we live to that uptick in the dosimetric index that Harold postulated. One of the problems we had is that installing in vivo and IGRT technology in particle therapy gantries are extremely difficult due to space limitations and pretty much all the money goes into this gantry. These gantries for protons and carbonides are very large and very, very expensive and takes a lot of stuff, so sucks out all the money out of the project. But also our patients demand more comfortable treatment positions. Patients with pulmonary complications, with pain and claustrophobia issues, really there's a paradigm that we can actually help them. The general cancer population today also favors upright treatments. Since early diagnoses, the patients are actually more ambulatory than they were 50 years ago. And the reason why I'm calling 50 years ago here is then all radiation therapy 50 years ago, 60 years ago was done in the upright position. But then patients were very sick and really needed to lie down to receive the therapy. We need to be able to use existing radiation therapy infrastructure for particle therapy. If we can start doing that instead of having to rebuild a brand new building, we will be able to save tremendous cost. And here is something that I think is really, really important based on the paper that was published last year, that we, all over the entire industry, we must find a way to reduce the time between the cancer diagnosis and the start of treatment. And I call this what I want to call progressive adaptation strategies. That means we should be able to start a semi-suboptimal plan, start the treatment really fast, and then optimize the treatment. But that really means we need to be able to do adaptive therapy, not because something had changed, adapting the plan because we can continue to make a better plan as we already start the treatment. Next, I want to talk about just a couple of 4 research papers that support upright patient positioning and treatments. And the first paper that was published in 2013 by the group from MD Anderson with Lawrence Court, the senior author, they looked at the advantage of simulating thoracic cancer patients in an upright position. The second paper has tremendous value in this space is a paper from the MGH group under leadership of Thomas Bortfeldt. Susu Yan did a great job, and also Jay Flans contributed here to really assess do a reassessment of the necessity of proton gantries. And basically what they concluded, if you use a fixed beam room, but you do a lot of things in terms of how you deliver the beam, pencil beam scanning, and how you position the patient, then the conclusion was then you probably don't even need gantries because of the benefits of protons having the Bragg peak and stopping in the patient. The MD Anderson group then came back with another paper in 2016 and talking about the reproducibility of patient setup in the seated position. And they proposed a novel treatment chair design. And here's a paper from the group at PSI, that's actually an older paper, 2007, but looking at systematic errors in respiratory gating due to intrafraction deformations of the liver. So I'll come back through each of these papers in the next couple of slides. But I want to first talk about the LEO cancer care approaches and technical solutions towards upright treatments. This diagram is a flow chart that I have to credit an old friend and colleague of mine, Joe Couture, that I worked with in Indiana University, that he was able to really simplify the treatment control process. And what happens here is you get a request for a treatment issued to the system via the OIS, and 2 parallel processes would take place. The one is preparing the beam, and this is the same for all forms of radiation therapy, while the other part of the control process to position the patient. And then many feedback loops to check whether the patient is in position, whether the patient remain in position, and when these feedback loops are satisfied and the upper feedback loop is satisfied for beam delivery, you can switch on the beam and it results in a treatment. Now, if you look at historically at developing treatment machines, then we know that 95% of the treatment time is spent around positioning the patient, making the patient comfortable, and getting the patient ready for treatment. But only 10% of the cost of developing a treatment therapy system is pretty much in this thing. And that's rightfully so, because the beam, of course, is very important. We need to deliver the beam correctly. But I'm of the opinion that we've done enough now, and beam delivery systems has reached a certain level of maturity that we can now start focusing on patient positioning. And if you can come up with a method where we consolidate the patient positioning effort over all forms of radiation therapy and standardize it so that they all are the same, then we can reap a lot of benefits. So the LEO cancer care approaches is that we have embarked then on a consolidated or a comprehensive patient positioning control system Where we want to see everything in this gray ellipse has to do with collecting data from various other systems, all kind of what I call patient alignment systems that would feed the information into this comprehensive patient positioning control system that then transfers the information to the patient positioner, the CT scanner, and the positioner, which I'll discuss in a minute. And everything is driven out of one single graphic user interface. And if we can achieve that, and we're of course on track to achieve this, then we can also incorporate future inventions. When somebody comes up with a device that is really innovative, then that could seamlessly integrate into this to the benefit of the patient in the setup process. And the therapist can now be much more efficient in running the system because they don't have to jump between different screens. One of the problems we see today in modern radiation therapy systems that very few of these devices that I show here in the blue bubbles are actually fully integrated. Often you buy a great piece of equipment, optical guide and surface tracking is one example, but the therapists have to go to another screen, another user interface to type in the patient's name and treatment plan, and that way they really stop using it. Now, how are we going to do that? And here's where I think we can learn a lesson from a golf master. I tried to Google it and see if this is true, but I actually liked the story. I couldn't really find whether that's true, but somebody told me once that somebody asked Jack Nicklaus, how do you win in Augusta? And his answer was, if you want to win in Augusta, you start with the ball in the hole. So you start on the other end of the golf course. And then if you want to get the ball in the hole in one putt, then where do you need to be on the green? And if you want to be there on the green, where do you need to be on the fairway? And so you work your way back to the tee. And I think the similar principle is what Leo now is following in rethinking this paradigm. So let's start with the thing that we need the most, and that's a positioning and imaging system designed exclusively for upright radiation therapy treatments. And how do you do that? So many years ago, probably 3-4 years ago, Stephen and some folks in Australia started looking in with also Paul Keel that was involved in this process to say, if we want to do this and we want to change the paradigm of positioning patients, what do we need to do? And is it possible to come up with a single device that can allow us to treat patients in the head and neck region, in the breast and lung region, thoracic space, or also in the pelvic region? And in what postures do we need to be able to position the patient to treat all cancer cases? And they came up with this very unique concept of a device that can actually do that. And if we go to the next slide, then we can see here we have a device. It's called the Eve Patient Positioner that can convert from a situation that looks more like a chair for a seated treatment that we use for head and neck and intracranial treatments. The backrest can tilt forward, and we'll show that in a minute in a video, so the patient can be in a forward-leaning position. And we also have this so-called perch position, where the patient is in a semi-standing position, and this is for pelvic treatments. Then, of course, once we have this patient positioner, it's very, very important that this machine now is so unique and different, and would have so many other settings and nuances to get it in position, that it has to be fully supported by optical tracking. And this is a statement that I think is true, is that optical tracking or surface guidance are probably the most neglected technology in the radiation therapy industry. It's extremely low-hanging fruit to look at the external surface of the patient. And a lot of times people say the external surface doesn't track with the internal organs, but for sure, there's a strong relation within the fraction, intrafractionally. That's certainly true interfractionally, but within the fraction, that is true. But we can learn from the developments in the auto industry. If we just look at what is achieved in the last 30 years from a machine vision perspective, there's hardly any car engine that's not manufactured today completely by a robot, by just using machine vision, and not even to talk about autonomous vehicles. So here's just three pictures of a standard off-the-shelf 3D camera, and you can see the incredible detail you can get from that camera. Here's a camera of a 3D picture of myself and one of our therapists. I had to cover her eyes here so nobody recognized who was this Chicago Cubs supporter. But you can see this enormous information you get in terms of even skin color. This 3D image gets you a full volumetric image of the patient external surface, but you can also derive information about skin reactions. It's just a ton of information. So we are developing a comprehensive optical tracking guidance system that will supplement our patient positioner. So with the patient positioner in place, then what about the CT scanner? So we then have a CT scanner we wrap around the patient positioner, and here you can see how this scanner would function. It's a 85 centimeters bore of the CT. If the patient goes in, you can see how the backrest is synchronized with the scan angle, and we can see the scanner ring just comes down and go back up. This scanner ring is fully counterbalanced, so one can actually deploy it just by hand. And the technical parameters that it will have a 75 centimeter field of view and be dual energy right from the beginning. So this device was actually the missing link in enabling upright treatments. So this is the under construction right now and will be installed in a clinic in Europe towards the end of the year, early first of next year. But you know, a lot of people know this, that this was done before. We had upright CT scanners, and here's an example of a scanner that was developed by EMI. EMI, of course, was the company that built the world's first CT scanner, and they developed this device, which I have a cartoon drawing here that I got from George Chan, and this system was installed in Lawrence Berkeley Laboratory and also MGH. And then this is a system that was installed in HIMAC facility in Japan. And here we have a scanner that was installed at the Fermilab neutron therapy facility, where the scanner will all come down vertically around the patient. But the problem is this was early days. I mean, this was 1980 to 1990, 2004 was when this machine was commissioned. These scans were extremely slow. 30 to 45 minutes just to scan the patient, which then led to patient fatigue and unwanted motions and discomfort, and really gave the industry or the concept of vertical scanner a really negative thing. So I call these scanners, they were a great idea, but they were really workflow killers. Because you can't, if it takes you 45 minutes just to scan a patient, by that time, the patient is tired and fatigued. So now we came with a Marie dual energy CT scanner. This picture just shows if you use the machine just purely as a diagnostic scanner outside the treatment room. It has the same patient positioner, but you can then put that same system inside the treatment room, for example, in a fixed proton beam. And this ring can come down right at isocenter and scan the patient at isocenter, retract and treat the patient. But the machine can also pivot around this point and can be used for in-room CT scanner, or we're also developing a mobile gurney in this case, that this scanner can also be used as a standard CT simulator for supine scans. Important to note that now this scanner is designed to give you a full dual energy CT scan. A typical dual energy CT scan significantly less than 1 minute scan time. And compare that with that 30 to 45 minute scan time of the previous generation scanners. That's a huge improvement. I do have to just re-emphasize that this is a scanner developed for upright radiation therapy treatments, but we can of course also use it for diagnostic scanning for patients with pulmonary thoracic patients that has breathing problems. A question that often comes up is, what about the coordinate system? So we have this fancy upright scanner now, but how does that look in terms of the coordinate system? So here I have I'm showing a GE scanner, a typical commercially available diagnostic scan that a patient goes in a supine position. And if you look at the coordinate systems, I think I'm correct. This is a left-handed coordinate system with the z-axis in the superior and inferior direction of the patient, the y-axis anterior, posterior, and x lateral, and this is what you get. Now, if you go to the Marie scanner and you do the same, then we can actually see that the coordinate system is exactly the same. We still have scan along the long axis of the patient, and y and x-axis is the same. So basically, the coordinate systems for these two scanners are identical, which then leads us to what happens in terms of treatment planning. So here we see a picture of the same patient that was scanned supine in the Chicago facility, where they have a PQR upright CT scanner. And here in the bottom line, you see the upright scan. If you look closer, you can see that the upright scanner has a curved backrest, which is basically just the backrest of the bed of a CT scanner they use for the backrest. The bottom line is then the treatment planning for upright and supine treatments are are exactly the same. What the physician sees in terms of how to do the treatment plan is the same, but some TPA vendors are now already supporting the upright treatment planning system. So in that case, what you have to do now is you say you have the patient in an upright position. So instead of rotating the gantry to achieve a different beam angle, you're now going to rotate the couch or the patient positioner. But fundamentally, there's really no difference in how you look at it. So now what is the workflow benefits of upright imaging and positioning? And there's several anatomical benefits of upright positioning that will really improve the patient positioning workflow, and we'll walk through those. The most obvious one is the lung volume and lung motion, and I'll show you a couple of data on that. Benefits in terms of pelvic organ positions and abdominal drift of some abdominal organs. But patient comfort will improve patient setup and reduce motion, right? So if the patient is more comfortable, we also know that will have huge benefits, especially for patients with pulmonary problems that cannot lie down, patients with neck pain, patients with claustrophobia problems that cannot tolerate masks when lying down. And just in the last 9 to 12 months, while I was still working at the Provision Cancer Center, we had 4 patients that we couldn't treat on the gantries really comforted because these patients suffer from all these problems. So the first paper I want to quickly highlight here is the paper by the MD Anderson group by Yang, looking at what they did is they took a bunch of patients and they scanned them in an upright position using a Phonar MRI scanner, 6.6 Tesla MRI scanner, and they found that the lung volume in the upright position is substantially larger, up to 25% larger, and this data has been confirmed by the group in Chicago that right now scans a lot of patients on their upright CT scanner. Now, of course, because for the same tidal volume now, because you have such larger lung volume, your motion is going to be significantly less. And this is the data from this publication that shows your typical movement, your excursion in the superior and inferior direction is on average about 4 millimeters less when you have the patient in the upright position. That means there potentially is going to be a significant reduction in the need for motion management, since most lung targets will move less than 5 millimeters. And we know that 5 millimeter threshold is set by the AAPM task group to say if the excursion is less than 5 millimeters, you really don't have to do much. So just this morning, IBA had a webinar on motion management, and the speaker there showed this data. It shows that 25% of patients could benefit from active management of motion. But we also know that active motion management prolongs the beam delivery significantly. They reported up to 45 minutes per lung treatment in some of these proton centers where you do active gating. That means the beam gets gated on and off. So if we can reduce the motion so that the majority of the patient, let's say this number comes down to 5%, then that has a huge impact on the throughput and the efficiency. And also there's less interplay, and that means faster and more accurate treatment planning. We spend an absorbent amount of money to making moving lung tumor plans robust so that you can trust the dose distribution. So if the upright position allows us then to reduce the motion, that we don't have to do motion management, that will have a huge impact. Here's a slide that I like. If you look at the snapshot in the life of a patient, the patient wake up typically at 8 o'clock in the morning. The patient just spend his whole night in the supine position, but from there on, the patient is in upright position. And let's say the treatment slot, the treatment schedule is around about 1 o'clock in the afternoon, then the patient is in an upright position all the way long until the patient have to go lie down for the treatment. Now, here's a paper from the group at PSI, Paul Scherrer Institute in Switzerland, that looked at the liver position. And so they put a bunch of fiducial markers in, and they did some cine loops and look at what happens over time with these fiducials in the liver. And it was actually interesting to find that the liver drifts quite significantly over the time, and they only stopped drifting after 35 minutes after the patient was being laid down for this study. The question is, so what? But if you look at the magnitude, then we can see that this drift could be as much as 20 millimeters, which really means that if you lay the patient down to treat, but the liver is keep on drifting, and when you get to field 2, you might find you might have to make a significant adjustment of the treatment position and keep on adjusting the patient because this drift happens. And we can safely assume that no organ drift is expected in the upright position because the patient spent most of his sort of time in the upright position. And that also means if there's no organ drift, there's no need for repositioning the patient, and it means that will result in improved throughput. The paper from McCarroll, the MD Anderson group, looked at many other factors, and here's what they proposed how this chair could work. And this was a chair attached to the end of a Linac couch. But they had the patients, so these patients received treatment in the supine position, and then they put the patient up for I don't know if it was a placebo treatment, but they didn't treat the patient in the upright position, but they did the full imaging sequence and have the patient in the position, and then the patient could fill in this questionnaire. And it's interesting that in most cases, the upright position was equally comfortable or even better or more preferred. That just means if the patient has improved comfort, there's going to be less involuntary movement, which again results in improved throughput. One other thing that is important in this regard is that if you think about the patient just coming in, sitting down, it's very easy to sit down. You're pretty much immediately ready to receive your immobilization devices, and you don't have to spend the time going from upright to supine. We also embarked with the folks from the University of Surrey, and that's a project that was under leadership of Stephen, where we did a very comprehensive study, putting a lot of fiducial markers and optical tracking systems around the patient, and actually put the patient into a mock-up of the Leo Eve patient positioner. And we can see here's a volunteer in this upright position. And these studies really corroborated the findings of the MD Anderson papers, the McCarroll and Yang papers. But it also revealed huge benefits in the arm position required, and knew there's going to be some typos here, for the upright breast treatments, right? So when you have a situation where you can actually have the breast drooping down and in the leaning forward position, there's no need to now lift the patient's arms above the head anymore. And if you could have the arms just supported in a position that just high up enough so the beam can squeeze in underneath the arm, then because the breast now droops forward, that has a huge impact from a patient comfort. And that is testimonies from ex-patients that volunteered that was used in this study. So again, this study told us that positioning a patient in an upright position could be quite comfortable, and it, as I said, supported the motion parameters that was found in these other papers. Then we also embarked on a study to look at pelvic organ motion, and we had a visit to the FONAR headquarters in early this year, and we scanned 2 volunteers in the supine and upright position and looked at the pelvic region. And here's the images for one of the volunteers with a full bladder in the supine position, full bladder upright, and then an empty bladder in upright position. And if you look carefully at this data, then it's very revealing that in the supine position, we could see that the distance between the sacrum and the bladder is actually larger in the supine position than it is in the upright position. So the red arrow here is the distance from the bladder to the sacrum in the supine position, which then of course opens up this channel for small bowel to droop in and coming down in the proximity of the prostate. The reason how I would explain that is that if you have the patient in the supine position and the abdominal content is now having a force vector in this direction, which actually can push the bladder up and away from the sacrum and actually force maybe small bowel into this channel and close it down to the space. Now, if you're in the upright position, then the abdominal mass of the patient would actually come and have a force vector in this direction, forcing the bladder down and squeezing the bladder onto the prostate action. If you then look at what happens with the prostate position as a function of bladder flow, then it's very revealing, and you can see the bladder position didn't even change whether you had a completely full bladder or a completely empty bladder. And this is unheard of. If you were in the supine position, the prostate would have tremendous drift because just of bladder flow. So no significant change in the prostate position as a result of changes in the bladder flow. The next slide I want to show to you, and this is just very speculative, but I made a little simulation here for a single field treatment in the supine position, in the upright position, and now using the upright technologies that we've developed. That means we have a fully engaged dual energy CT system at IsoCenter, fully supported by optical tracking. And the current paradigm is a supine situation where the patient has to walk into the room. That's the same time. Then the patient entering the room sit on the PPS at the same time. But now to make the patient comfortable in an upright position is certainly much, much easier than having to lay the patient down. I talked to a therapist the other day that said they have endless problems. Sometimes just laying the patient down and the patient becomes uncomfortable. They have to be set up again. And if I just look at these three bubbles that I'm highlighting here, making the patient comfortable on the table, verify the setup position, or getting the patient off the PPS, something as simple as that. I mean, we have an upright position, we need to just drop the positioner and take the immobilization device off, and the patient just stand up and walk out of the chair like you're standing up out of a chair. If you just look at these three bubbles and all these other cases, some cases, of course, I will take more time in the upright position. For example, installing the immobilization devices might take a little bit more time. And but overall, I came up with just a simple scenario to say we can easily have a 6-minute time saving just going from supine to upright. So that will mean, simply because it's easier to reproduce that, maybe we'll see some significant time saving. Now, what is the challenges? Certainly some things is not resolved yet. And a couple of remaining challenges that I want to highlight here is it's the lack of high Tesla upright MRI scanners. We used to have most of our patients, and certainly that's true for prostate patients, now gets a high Tesla, a 3 Tesla, at least above 1.5 Tesla MRI scans. And for that, we are embarked on the formal registration studies to investigate this, and I'll show a slide about that. There's certainly a lack of knowledge about anatomical data in the upright position, and for that, we're doing all these studies. We will continue the study with FONAR to scan 13 more volunteers and look at the abdominal changes. But then there's also the question, what about anesthesia or a sedation of patients in the upright position, pediatric patients, how we deal with that? And then what about non-ambulatory patients, paraplegic patients and quadriplegic patients? So we'll go through these one at a time. So here's just a little graphic showing how we think we work with this lack of upright scanners. And what we want to do here is to embark on a study where we would obtain a supine high-resolution CT, obtain a high-resolution upright CT using the Leo scanner. Then we can obtain a supine MRI scanner. For this, of course, we'll need to use IRB approval and get some existing patients wanting to volunteer for that. And if we can also obtain an upright MRI using a low Tesla upright MRI scanner, then we can do a formal registration and obtain the CT to CT deformation map between the CT scans. We can apply that deformation map to the supine MRI scan and calculate a deformed supine MRI, which now, if the deformation map is applied correctly on the organs that you are interested in, and for example, you'll have to exclude, for example, something that's very easily identifiable, like the bladder, for example. And then we can do a 3-way comparison just using rigid registrations between these three, which now should match up if this deformation map matrix is working right. Now, what about patients requiring anesthesia or sedation? There's no doubt that we would need special attention from an immobilization perspective. We might have to make custom backrest and custom child seats might be required to position a child in an upright position for anesthesia. But we know that children often wake up when you try to lie them down. I want to attribute this slogan here to Dr. Christian Hyde when I talked to him about it. He's a pediatric radiation oncologist. And he said it might actually be possible to reduce the age of children requiring sedation or anesthesia in the upright position. And here's just like a cartoon where the mother rocks the baby to sleep in upright position, and then as soon as she lies the baby down, oh no, the baby is woken up. And so we've all been through that, and so I'm optimistic that that is a real possibility. But there's other benefits. And these benefits might just outweigh the challenges. And these are like intubation is easier in upright position, patient breathe easier, and there's less asphyxiation in the upright position. So these are pluses. But as I said, we still need to deal with this. Now, what about non-ambulatory patients? And so moving a patient from a wheelchair into another chair is a well-established and defined technique. Here you can see somebody moving a person from the wheelchair into a motor vehicle. A lot of patients in wheelchairs actually can drive the motor vehicle. So that is a fairly decent process, and it should be easy to bring this patient, which is paraplegic, into the Leo positioner. But what about quadriplegic patients? And as I started looking around at that, I found there's just a lot of work done in the field of quadriplegic patients where you have these devices, a wheelchair, it can translate from a seated wheelchair into an upright solution, which very closely resembles this scenario for our patient position in the perch position. And so we need to find a way to translate the patient from here to there. But I want to point out that the key thing in this entire positioning process I haven't pointed out is the knee stop is the key innovation in upright positioning. This, of course, allows you or stops any probability of slouching down as the patient would slide down, and because the knees are stopped, and the same here. So think about a quadriplegic patient. If you can hold the thorax up like this person here is held back towards the back with this brace, you do something similar to that, then the gravity will force the patient down and slide into the knee stop, and I think it could actually work really well. Which then says I do really need special and additional design consideration will have to be put into the space, and it means we might have a special backrest, have special stuff here to do that, but certainly very doable. As I prepared that, I just had this, I found this picture. I just thought that upright position might just be a huge improvement in treating non-ambulatory patients, and I'm really excited to start working in this space. Now, one last, almost done, 1 or 2 slides here is about the size and cost. How would that improve efficiency in construction and other timeline benefits? And here we just show a picture of how would this upright proton therapy system fit in existing 2 LINAC bunkers. It's very easy to fit most of the existing cyclotrons and some of the synchrotron vendors that can fit the accelerator in 1 LINAC room, punch a hole through the back wall, and we put the Leo positioner, upright positioner, and dual-energy CT scanner plus beam over nozzle in another LINAC room, which now means we can put a proton machine in the space of 2 LINACs. And there's, of course, other models that can even do maybe 2 treatment rooms in the space of 2 LINACs. Those are plans that exist. This is there's a video out on YouTube, and you can also see this video how I explain this difference in size. If you build a gantry room, if I take the base, the footprint of the gantry room, and I expand it up to the ceiling height, up and down, because the gantry needs to rotate, and then I look just at the space around the isocenter you need to treat the patient, and I expand that into 3D volume, then we can see for the typical IBA room temperature gantry, which is the same for the Hitachi room temperature gantry and the Big Varian room temperature gantry, that volume of between IBA and fixed is around about 19 times less shielding. But if you take the smallest 360 gantry ever built with the Pronova gantry, then that ratio is about 10 times. So think about constructing something that 10 times smaller or 19 times smaller ought to be much, much faster. And then even if you can reuse existing infrastructure. Now, in conclusion, I just want to remind you what Schopenhauer said in, he was a philosopher in the 1700s, and he basically said that all truth passes through 3 stages. First, it's ridiculed, and people say this is a dumb idea, this is just wrong. Secondly, it's violently opposed, and then thirdly, it's accepted as being self-evident. So upright treatments will improve radiation therapy. Sorry for that typo there. Upright treatments will improve radiation therapy due to the fact that it will have improved workflow and patient position efficiencies, reducing reduction in equipment and facility size, and enhance patient comfort. Right? And I think soon upright treatments will soon be regarded as self-evident per the Schopenhauer. So that means we're almost here at the third stage of Schopenhauer, and that really concludes my presentation for tonight, this morning. Thank you very much.
Wonderful. Thank you, Nick. That was a really fantastic talk. We have a few questions to go through. So I will read these out and let you come back with the answers, Nick. So the first one that we've had here, is it possible to do treatment planning? And if so, with which TPS?
Yeah, so it is definitely possible. The folks in Chicago is using the upright treatment scenario now for quite some time. Actually, we did it a long time ago using the XIO system that was developed by Elekta. And recently then the Chicago folks switched over to RayStation. And RayStation in their latest release, the 9.9B release, will have the ability to do upright treatment planning in a true fashion. The Chicago folks used it, but they had to manipulate the DICOM image just to rotate the beam coordinate system. So clinically released right now, not fully clinically released, is the latest version of RayStation will do the upright treatment planning.
And it is a question that we get fairly regularly, isn't it, Nick, about treatment planning? But I think if you think about it, you know, the images that you're collecting, as you pointed out with the coordinate system, you know, it's essentially the same data. You're going through the same process. It doesn't really make a huge difference whether it's upright or supine.
No, not at all. I mean, I think the only difference there is that the anatomical data, and when the doctors start drawing these structures in, you just have to make sure you have comparative data but from the treatment planning user interface, and as I said in the talk, just how you put the beams in is slightly different by having to rotate the patient versus rotating the ante. Now, also, I must say, in the 90s, the first 500 patients that I was involved in treating with protons was all in the upright and seated position. But there we use kind of homemade dedicated treatment planning systems.
Okay, the second question we've got, Nick. Infants prefer sleeping upright and held in a carrier, either on the parent's front or back. Could we use a cloth child carrier to support an infant?
Yeah, absolutely. And this is why I'm so I have not said that, but this is the value of having dual energy CT at ISO Center. So I'm a big proponent, and one of the 8 things I listed in my BJR paper is the notion of taking the beam to the patient. You know, so you can argue that if I have a full CT scan and I can do a low resolution CT scan just for patient positioning, I might as well do an adaptation and take the beam to the patient. And in that case, as long as the patient is more or less in the right position, of course, depends on the type of tumor, where you're treating, then we can do an adaptation. But that certainly would be the way to go. I have no doubt that the way to do it is to make the patient asleep through sedation or anesthesia, and then mount the young kid into this immobilization device to hold the patient in the position. But that's exactly the thinking, yeah.
And then the next one we've got, Nick, how about collaboration with current vendors like Varian, Elekta, Research Labs?
Yeah, so there's two activities going on here. There's a huge need, of course, to be solved in the proton therapy space. So the proton therapy space is the driving force, and the easiest for us would be to go to a greenfield site and say, let's just go build this system from scratch. But it's hard to just convince people. So we are actively working with several existing proton centers and say, is there a way that we can work with your vendor to upgrade most of these fixed beam rooms and upgrading it towards an upright treatment solution by bringing the Leo products in and de-scoping the current typical robotic positioner that's in that. So we are actively engaging with at least 4 or 5 out of the 8 vendors to see can we do that. And we have some huge strides with many of the vendors. So that is an ongoing process, and we're making good strides. The goal is to have everything that Leo produces, have everything FDA approved by the end of next year. The first installation will happen towards the end of this year, and that installation will be used towards the FDA approval process.
Perfect. The next one we've got, Nick, you show a vault with no maze. Is it possible to put a neutron door onto a conventional photon beam vault to accommodate proton radiotherapy?
Yeah, absolutely. The benefit of upright treatments is that the beam and the neutrons is now only produced in one direction. So what you would do is you would certainly not shine. You would try and design it such that the beam direction is not pointing towards the door, and then you would just use big sliding doors and calculate the shielding going to that. But the whole idea would be to direct the beam such that you hit the beam into the corner of the existing LINAC room, and that corner can then easily be beefed up in terms of the shielding, so that all the neutrons that is produced in the forward direction will hit that wall, and then you can work with boronated polyethylene sheets to capture the thermalized neutrons. So the shielding actually really becomes much easier. Of course, you have to have very thick wall where the beam hits it, but you don't have to now correct for all different beam angles.
Yeah, absolutely. So another question here, Nick. What is the dual energy CT technology? Is it fast KV switching, rotation or detector, or filter based?
Yeah, we are still working a little bit of invention disclosures in that regard, so I can't disclose everything, but it's based on a filtered energy filtration method, and that's why we can do it so fast.
Yeah. Then why do you need a separate diagnostic upright CT if you can get it from the treatment room?
That's a really good question. I'm glad you asked that. So if somebody would have two treatment rooms, for example, it would make sense to do cone beam CT in the treatment room by just rotating the patient in two stationary X-ray fields. So it's very easy. I didn't have time to show that, but cone beam CT at ISO center with a very precise rotation is going to be very easy. And then you have your upright CT scanner outside the room to do the CT scanning for treatment planning. So we also believe that the scanner has tremendous application for just the CT scanning in the upright position with patients, because again, if the lung volume is larger, you're going to have so much better lung imaging. And if the lung motion is less, the quality of the thoracic image is also going to be better. So we do believe that there's a need for just a diagnostic scan that you can scan patients at position. But this is like just having the different options. If somebody says, I want dual energy CT in my treatment room, then you can have that. If you say, I want to treat maybe just more head and neck and intracranial patients where I really don't need that much, I use my 3D volumetric imaging more for patient setup, then cone beam CT would be adequate for that. If somebody says I'm treating a type of tumor where I expect a fair amount of adaptation, where I need dual energy CT or high resolution axial CT, then clearly you can install that in the room as well.
Yeah, I think the ethos and the way that we've developed all of this technology has all been based around flexibility. So offering the ability to integrate dual energy CT into the treatment room, as well as having the option to do CVCT, gives you the option to do whatever it is you want and whatever you deem necessary.
So one point that I didn't make clear in this regard is that this is the first time now, and I'm really looking forward to that, is that what you have in your CT scanner, you're also going to have in your treatment room. So it's identical, same position. It's not that we now have a CT scanner couch that was redesigned for diagnostic imaging, and then we have to take it to the treatment room and make a nice curved bed into a flat top, and then have all these support structures that gets in the way of the beam that you have to either correct for or have to make sure the beam doesn't go through it. Whatever is in the CT scan is going to be in the treatment room and is what you're going to treat through.
Yeah, absolutely. So one more here for you, Nick. It will be important for QA will be important for the Leo Cancer Care solution as well. Which vendor solutions do you have and plan to collaborate with?
We have not started actively on how we going to do the QA. Well, as we think our first facilities will probably be existing proton facilities, and we'll just have to continue to work with that QA systems. But there is no reason why the existing QA apparatus offered by the various vendors wouldn't be able to use. Of course, we don't have the ability now to have a flat tabletop anymore to put these devices on. So what we'll have to do is to develop mounting jigs that can attach to the backrest of the patient positioner to position the patient. But I do think there's an opportunity here to come with new paradigms. I do think we really want to do the log file-based QA. Is also log file-based QA is one of the 8 things that we identified to really improve efficiencies in how we operate this system. But I see the QA will still be based off the standard ionization chamber type measurements and scintillators and so forth.
Yeah, I think absolutely. And, you know, the important thing that we've identified with this is, you know, we are making a change to the technology in some respects. And I think it's important when you make such changes to the technology that you try and keep the workflow as similar as possible, and that you either change the workflow or you change the technology, but it's very difficult to do both at the same time. And I think what we've done very well throughout the whole development of this patient positioning device is keep the interfaces to the backrest very similar to those to a conventional tabletop. So a lot of the immobilization devices, QA devices, actually work very well in the upright orientation as they do supine. So working with those vendors and both on immobilization and QA, we can actually keep the workflow very similar to the supine orientation.
Actually, the QA is actually, it is very important that one of the huge pluses of upright is that you're only going to have one gantry angle to deal with. And all the QA we have to do nowadays to look at gantry isocentricity and all those parameters, everything collapses into this much, much simpler scenario. A great example is the folks in Chicago always love to see that. They're using their robotic positioner to go fetch the CT daily QA device, and the positioner just puts the daily QA device right into their CT scanner. So then they can check the accuracy of the positioner and the CT scan. So there's a huge amount of benefits are going to come out of that. In fact, that's probably a talk on its own, the efficiency we're going to see around just the normal daily, monthly, annual QA of such a system.
So 2 more very quickly, Nick. This is a suggestion to reduce the cost of upright positioning. And it's a statement that says there's no need to put a CT scanner in each proton treatment room. We should specify a purpose on the disease site to avoid a CT scanner in each room.
Yeah, no doubt. The benefit of that we have here is that this now opens the door for us to put all kinds of image guidance in the room. I have no doubt that I 100% agree. If you have 2 upright rooms, probably only one is going to be the one that's going to be used for adaptive therapy where you have to dual energy CT. Now, also, I have to say that these dual energy CT is not that expensive. We're trying to be really cognizant of the cost. And so at the end of the day, it's not going to be such a huge cost driver. You see the pluses, then and the size savings, then maybe there's a good argument that you might want to put them in each room anyhow.
So just to end on this final question, it's a pretty quick answer to this one, but when do you plan to treat the first patient and where? There's very little that we can say on that at the moment, but I'll let you answer that, Nick.
That's a CEO question answer, you know, but also there's no short answer for me, but clearly our first project is a European site where we're going to do all the prototyping, but they might not be the first people to treat. We do believe the first treatment will be in one of the existing proton therapy centers where people are extremely passionate to move this technology forward.
Yeah, and I would say, you've given the timelines need to deliver that first unit. We've said at the end of this year. We'll be making a series of announcements about that very, very soon. So yeah, not a huge amount of information that we can give away right now, but keep your eyes peeled for some announcements on that very soon. So we'll bring it to a close there, Nick. Thank you again for a really fantastic talk. And thank you to everybody for joining us and for some brilliant questions. So stay safe, everybody, and we'll speak to you soon.
Thank you very much.